Welcome back to the second part of the opioid prescriber training program. As a reminder, all prescribers with DEA numbers and medical residents prescribing under a facility DEA number are expected to complete this training, and it consists of a minimum of 3 contact hours of coursework or other training in pain management, palliative care, and addiction. Compliance for the initial cohort was expected by June 30th of 2017, and for all of you that are now taking this applies to all new practitioners after this date, and then anybody undergoing license renewal. For this portion of the course, we are satisfying the New York State mandate to cover prevention, screening, and signs of addiction, response to abuse and addiction, palliative medicine, and end-of-life care. The objectives for Part 2 are to describe the appropriate considerations in managing a patient's pain to prevent development of addiction, to identify and evaluate risk factors for development of substance use disorder, to describe screening tools and processes that may be used to identify signs of addiction, and to evaluate patients seeking pain medication and discuss appropriate treatment approaches based on whether the patient can be identified as in chronic pain, addiction, both, or neither. Upon successful completion of this program, an ACCME CE certificate along with a letter of completion will be issued via email. The link provided below, as well as elsewhere throughout this course, provides information about uploading this information to the attestation site of the state of New York. Thank you for your participation in this course.
My name is Rick Blondell. I'm a professor in the Department of Family Medicine here at the University of Buffalo. And I'm presenting in the Opioid Prescriber Training Program Part 2, and the topic is prevention, screening, signs of addiction, and the response to abuse and addiction. As an overview, most of you know that there is an epidemic of opioid misuse in this country. Illicit prescription drugs have served as a gateway to illicit drugs, which has led to this epidemic of opioid misuse. And we're not going to be able to treat our way out of this epidemic. Prevention has always been the best way to deal with epidemics. Epidemic of opioid misuse. And how did this occur? Let's look back into 1999. As you can see from the left-hand side of this slide, back in 1999, deaths due to opioids were not as common as they are today. What happened in 1999? 2 things. 1, doctors were encouraged to always treat pain. Hospital accrediting organizations required pain as the 5th vital sign, and new products were introduced to the marketplace, including OxyContin, which were heavily promoted. This led to a rise in the number of prescriptions, and paralleling that rise was opioid deaths. Now let's look at what happened about 10 years later. Deaths due to prescription drugs tended to level off as state prescription monitoring programs came online and physicians became a little more conservative with their prescribing habits. But what happened was the patients who were dependent on these drugs did not go away. And the illicit drug dealers who sold heroin or fentanyl or other products came on the scene to meet this need, and we can see that this led to further increases of opioid-related deaths. So prescription drugs can serve as gateway drugs to illicit drug use. Let's look at an example here of one study that was performed in a drug detoxification unit. And investigators conducted an interview with these individuals to ask them how their addiction began. And 41% stated that their addiction can be traced back to that first prescription that they received from a physician for a legitimate cause. And that's what sort of triggered their addiction and led to years of abuse. Another third started using drugs from a prescription that was diverted from a friend or a relative. So this is only one step removed from a legitimate prescription. And then the final 27% started their addiction with illicit drugs. So you can see today that the majority of patients who are becoming addicted to drugs started with illicit prescription. As a response to this epidemic, there have been a number of recommendations. It's been recognized that a number of people have become addicted to drugs, both licit and illicit, and treatment has been considered to be important and how to deal with this. So there's been recommendations for more detox services, more rehab beds, more treatment programs, better aftercare, the expanded use of naloxone rescue, more methadone clinics. But if you think about it, this approach is mostly damage control, fixing the problem that's already there. What we really need to do is to prevent the problem from beginning in the first place. So the prevention has always been the answer to epidemics. Let's look back at the polio epidemic in the 1950s. We did not really successfully deal with this epidemic by building more iron lungs and putting more kids in braces. This epidemic was beat back with a vaccine to prevent people from getting polio in the first place. Another example is cervical cancer, and gynecologists can teach us a lot about how to handle an epidemic. For example, at the beginning of the 20th century, deaths from cervical cancer were the #1 cause of deaths, and half of Americans couldn't get the disease. 100 years later, it was ranked number 10. How did we go from the #1 cancer killer to the number 10 cancer killer? As you can see, advanced cancer is represented on the right-hand side of this triangle: localized cancer, cancer limited to the cervix or the uterus, or metastatic cancer. Now, back at the beginning of the century, we knew about X-rays. Röntgen had discovered X-rays in 1895, and external beam radiation was applied to cervical cancer. The Curies discovered radium, and we figured out how to put it in pellets and implant it. Surgeons developed better surgical techniques after anesthesia was initiated with ether, and they had the ability to do hysterectomies through the vagina or through the abdomen. So by about 1920, we had most of the tools that we have today to deal with advanced cervical cancer. But we really didn't treat our way out of that epidemic. What we did was we recognized that cervical cancer began early with abnormal cells on the cervix. So we set up a system of pap smears and treatment interventions so that we would prevent the development of advanced cancer in the first place. So we shifted our focus a little to the left-hand side, and that's how we dealt with the epidemic of cervical cancer. Likewise, when we look at people who abuse drugs, who are addicted to drugs, that's sort of the tip of the iceberg. And our efforts to deal with these folks represent mostly damage control. What we need to do is shift our focus a little bit to the left of this and look at people who are in the early stages of addiction or who are just beginning non-problem use, and institute programs of screening and prevention in order to prevent people from progressing to a full-blown addiction. And that's how we're going to really deal with this epidemic. What we need to do is we need to stop prescribing patients into addiction. And that's our responsibility as physicians. First, do no harm. Before even prescribing that first dose of opiates for pain, evaluate the patient for risk factors of addiction. Make sure that you have an accurate pain diagnosis, and then prescribe wisely and only if truly indicated. Once you have prescribed opiates to an individual, continue to monitor them for the early signs of addiction and avoid prescribing them into full-blown addiction. And please exercise special care with young patients. Here are some of the risk factors for the development of a substance use disorder. A dysfunctional childhood, particularly with those with physical, sexual, or mental abuse. A history of attention deficit disorder, school problems, conduct problems. The early onset of substance use, particularly before the age of 14. So individuals who begin smoking cigarettes, marijuana, drinking alcohol, or experimenting with drugs before the age of 14 are at particular risk for the development of addiction. Obviously, anyone who's had a personal history of an addiction in the past is at risk, and those with a positive family history may carry the genetic predisposition for addiction. This genetic predisposition is mediated through changes in our genome. So we know that there are single nucleotide pleomorphisms, SNPs, which alter the basic structure of opioid receptors, which predispose people to addiction. We also know that there are changes in dopamine receptors, serotonin synthesis, and these things seem to then lead to this positive family history that would tip us off for individuals who are at risk for addiction. We must prescribe wisely. So before prescribing, evaluate for these risk factors. Make an accurate diagnosis. Recognize that non-opioids are usually the first-line treatment for pain. Prescribe opiates only if truly needed. And then check the New York State Prescription Monitoring Program before looking for abnormalities. Check a urine toxicology. Establish firm treatment goals. Use the lowest possible dose in the lowest amount for the shortest possible duration. Avoid prescribing benzodiazepines along with opioids, and evaluate treatment outcomes. We would expect to have a 30% reduction in chronic pain that would correlate with a successful treatment outcome. Use special care when treating young individuals. We really don't know what the impact of an exposure to opioids has on the developing brain. So the risk of the benefits of opioid use among those under 18 is often pretty limited. We don't know what the long-term consequences are of these medications. We know that adolescents who misuse opioids often misuse their own prescription. And the use of opioids before high school graduation, even just one prescription for an opioid before high school graduation, will increase the chance by 33% that that individual will later develop an opioid use disorder. And marijuana in the urine may be a special marker for those who are at risk for prescription misuse. Although we do screening at the onset of the use of opioids, it's not just a one-time process, and in fact, screening and brief intervention can be an ongoing event. So how do you screen patients in an ongoing event? Continue to check medical records, consider formal screening tools, query the state monitoring program, and obtain urine for toxicology. Keep checking the medical records. While patients are on chronic opioid therapy, they may have a surgical procedure, have other diagnostic imaging obtained, seen other physicians and received other diagnoses, and are being prescribed other medications by other doctors. A physician could use formal screening tools on an ongoing basis to screen for the development of addiction. There is the DAST, which can be adapted to clinical use, the Alcohol Use Disorders Identification Test, known as the audit, and also because many patients have anxiety and depression associated with chronic pain, monitoring performance on a Beck Anxiety Inventory or the Beck Depression Inventory may be helpful in determining the outcomes of the treatment of opioids. So for instance, patients who have chronic pain, who have a fair amount of anxiety and depression, if their pain is relieved appropriately without the development of addiction, one may actually see improvement in anxiety scores or depression scores. Check the New York State Prescription Monitoring Program. At the time of every visit when a controlled substance is prescribed, it's important to check the prescription monitoring program to look for physicians who are also prescribing controlled drugs to your patients. So you're looking for multiple prescribers and multiple prescriptions. Obtain a urine for toxicology. There are many companies that offer point-of-service urine toxicology testing that can be done in the physician's office. Many of these cups will have a temperature strip on there, and you would expect to have the urine temperature to be about 94 degrees. It's very difficult for someone to bring in a sample of urine and submit a specimen that's exactly at that temperature. We've seen patients who present with their own urine and will submit a urine with a temperature of like 108 or 50 degrees. And obviously that can't be a fresh voided specimen. If you have any question, consider having someone go into the restroom with the patient and observe them on sort of the urethra to bottle format to make sure that you have an accurate sample. And you can use these qualitative immunoassays as a screening test or a quantitative gas chromatography mass spec as a confirmatory test. Let's talk a little bit about the interpretations of these qualitative immunoassays. You have to remember that opiates are a subset of opioids. All opiates are opioids, but not all opioids are opiates. So therefore, the synthetic opioids such as methadone and fentanyl do not produce a positive test for opiates. Also, some opiates, such as oxycodone and buprenorphine, although they share the same basic chemical structure of morphine, typically will not produce a positive test for opiates because they don't cross-react very well with the immunoassay. Also, some benzodiazepines, such as clonazepam, may not produce a positive test for benzodiazepines in some immunoassay tests. Some over-the-counter medications, such as pseudoephedrine, may cause a false positive test for amphetamines. Environmental exposure to marijuana will rarely produce a positive screening test. So if some patient comes in and says, well, I had a positive test because I was at a party last week and somebody was smoking marijuana, that's not a valid explanation. An individual has to be in an extreme, unventilated situation for a prolonged period of time for just inhaling environmental air to produce a positive urine test. So unless somebody's been on a car trip with Cheech and Chong across country, you're not going to have a positive marijuana test just from environmental exposure. So interpreting the urine toxicology reports, you also have to consider the half-life of the drug that's being tested. So those drugs that have a short half-life, such as methamphetamine, lorazepam, cocaine, heroin, will only cause a positive urine test for just a few days or so. On the other hand, drugs with long half-lives, such as buprenorphine, the cannabinoids, diazepam, methadone, may cause the urine toxicology test to be positive for several days to a few weeks after the last use. Gas chromatography and mass spectroscopy remain the gold standard of toxicology testing because it will identify the specific drug that's in the urine. The immunoassays will only look at the class of drugs and may not actually give you the exact drugs. But GCMS will give you the specific drug at a quantitative level in the urine. The signs of addiction. Up to 25% of patients who are treated for chronic pain will develop an addiction. Most do not, but it's the 25% or so of patients that do develop an addiction that have contributed to this epidemic of drug overdose deaths that we've seen. In one study of patients with chronic back pain treated with opiates for addiction, about 25% went on to develop an addiction. And this does not happen quickly. Many times patients will take medication as directed for a year, 2 years, and up to 5 years before they actually slide into addiction. And it can happen very slowly, almost underneath the radar. Pain becomes worse as the doses increase, and this is known as hyperalgesia, also a sign of addiction. If a patient has pill counts that are inconsistent with prescribed directions, if a patient is getting multiple drugs from multiple prescribers, if a patient is coming into the office and submitting adulterated samples or samples that are inconsistent from one day to the next and not consistent with the prescription history. Now, it can be difficult to distinguish a worsening pain disorder from an addiction. There's been a term used called pseudo-addiction, which is not really a medical term. And there are some patients who are treated with a chronic pain condition who then develop a worsening because their basic underlying pathology is worse. So for instance, a back pain patient who's had previous surgical procedures could be at risk for herniating another disc and having some new pain. On the other hand, sometimes patients may be overplaying their pain in order to get more drugs to either misuse themselves or divert to the illicit market. It's a tough call, and it will test the clinical acumen of most physicians to try to separate one from the other. So what are the signs of addiction as seen in the DSM-5? Well, excessive use, a request for early refills, running out early, so forth. The inability to cut down even when requested by the prescriber, or seeking additional medications from the illicit market, spending a lot of time thinking about the drug, getting the drug, using the drug, and cravings. So those people who are craving drugs, not only for pain relief, but for the euphoric effects. And at the same time, their functional capacity at home or work, in school, is being compromised. There's a decline in interpersonal relationships and their psychological impairment. What does a clinician do if he or she suspects drug abuse or addiction? It's very important to intervene early in these situations because brief interventions by the prescriber early in the course can save lives. What can be done in response to abuse and addiction? The treatment is based on a careful clinical evaluation. Decide if the patient meets criteria for addiction. Yes, no. Decide if chronic opioids are truly indicated for the underlying medical condition. Perform some sort of intervention, such as the Frames method, which we'll talk about a little bit more later. Some of these patients may be treated in your own office. Others may need a referral to a professional treatment program. And we'll look at some clinical studies here. Now, the Frames model can be used in these clinical situations. So this FRAMES stands for providing feedback with concern to the patient, reinforcing the personal responsibility that the patient has, advising a specific plan of action, Plan A, offering a menu of options, so several other options could be a Plan B if Plan A is not successful or the patient does not want to participate in Plan A. Now, we're usually pretty good at giving advice to patients, What we also need to do is express empathy, acknowledge that this is a difficult situation for the patient. They may feel ashamed about what has been happening, and support self-efficacy. Don't kick them when they're down, but tell them that they could get better, there's a better life for them, they deserve better, and so forth. So let's now look at some actual clinical cases that we've actually seen here at the University of Buffalo. Now, in some cases, the little details have been modified, but all of these are based on real patients. So a 16-year-old comes in because she's jammed her finger while playing basketball, and she's requesting an opioid. And in fact, she's requesting a certain type of opioid. She wants some perks. It's noted in the chart that her biological father is known to have a substance use disorder. So what do we do here? This patient has acute pain and is at risk for addiction. So use the usual rest, ice, compression, elevation, along with NSAIDs for pain. Educate this patient about her risk for an addiction and the need to avoid controlled drugs, given her father's history. The fact that she's also asking specifically for a specific medication tells you that she's sort of familiar now with these drugs. If you do decide to use opioids in this person, use the lowest possible dose, the fewest number of tablets, the shortest possible duration. Usually, people like this do not need more than 3 days of medication, and by law, a maximum of 7 days. Be sure that her parents monitor her medication use. Now, this may be a problem if her parents are also misusing drugs, but advise them to discard unused medications, since unused medication around the home is often used for the euphoric effects or diverted to other people. I was taught in medical school that patients either had real pain or they were drug addicts, and my job was to figure out which one. I now know that this is not very helpful clinically. A better approach is to decide, does this person have an addiction? Yes, no. And does this person have a chronic pain disorder for which opioids are truly indicated? And by doing that, you'll be able to categorize patients into one of 4 boxes. Let's take an example of a 52-year-old who's requesting a refill of his opioid medication. He's had 5 different surgical procedures of his lumbar spine. He's had discectomies, a laminectomy, he's had implantable devices put in and taken out, and he is left with chronic pain, no question about it. His toxicology is appropriate for what's being prescribed, and in fact, he often takes less opiates than prescribed and tells the doctor that he only takes them when he really needs them. So here's an example of someone who has no evidence of addiction and verified chronic pain. So what we can do is to monitor his pain with an objective scale, such as a 10-point Likert scale, monitor his functional ability, such as a 10-point functional scale, check his pill counts, keep checking the state prescription database, monitor urine toxicology. And if he comes into the office with family members, you can ask them about how's he doing at home with interpersonal functioning, social functioning, and activities of daily life. A 24-year-old wants a refill of amphetamines, alprazolam, and hydrocodone. Her clinical diagnoses are vague. Her database shows that she's getting multiple drugs from multiple prescribers. And surprise, surprise, her urine toxicology is completely negative for all drugs. Here's somebody that doesn't seem to have a personal history of addiction as far as you can tell here, and no chronic pain. If she had a personal history of addiction, you would expect to have drugs in the urine. Another possibility is she's submitting somebody else's urine. But there doesn't seem to be any evidence of chronic pain here. So do not fill the prescription. Consider collecting the urine under supervised conditions and recognize that the risk of diversion in this individual patient is pretty great. A 42-year-old is requesting a refill of the opioids that he uses for back pain. Clinically, he just has lumbar strain, no history of surgical procedures, no herniated disc. His database also shows that he's getting alprazolam from another prescriber, and his urine toxicology shows opiates and cocaine, but no benzodiazepines. So this particular patient probably has an addiction. Any patient that has cocaine in their urine probably is addicted to something. And there's no evidence of chronic pain here. He has not had surgical procedures. His MRI scans were normal. And clinically, he just has muscle strain. So here, you could perform a brief intervention. We'll talk a little bit more of this later. Taper off all the opioids. consider non-opioids for pain, and if his addiction's severe enough, he might need detox or counseling. And also, this patient may be a good candidate for buprenorphine or even a referral to a 28-day inpatient treatment program. Let's look at this case. A 36-year-old is requesting a dose increase of her prescribed opioids. She has rheumatoid arthritis, and on examination, she has painful joint deformities. The state database shows oxycodone as she's being prescribed, but her toxicology shows hydrocodone, oxycodone, and 6-monoacetylmorphine, which is heroin. So this person probably has an addiction. But she also has a chronic pain disorder. So you're kind of stuck here. If you continue prescribing short-acting opiates, you actually may feed her addiction. But if you take the opioids away, her pain might get worse. Here, the physician could perform a brief intervention, stop the short-acting opiates, consider the use of buprenorphine, consider referral to treatment for a substance use disorder or pain psychologist, and maybe even consider inpatient drug rehab. Here's some basic techniques for brief interventions in the office, and these are based on the principles of motivational interviewing. Here, the philosophy is that most patients are motivated to do better. And what the physician does is to enhance that basic motivation and help them move to a more positive direction. Now, oftentimes this is not successful. We know that brief interventions will work maybe 20-30% of the time. So the physician has to be prepared for failure, like a Major League Baseball hitter. A good Major League Baseball hitter might have a batting average of 300, which means that only 30% of the time he's going to get a hit and get to first base. So the Major League hitter accepts failure as just part of the job. Likewise, the physician has to accept the fact that many times people who are addicted are not going to be amenable to an intervention, and that the physician's efforts may only be successful a minority of the time. But we have to really focus on that segment that we're going to help and not be too discouraged by the ones that we can't help. So these brief interventions can be very effective, last only about 5 to 15 minutes, can be accompanied by a video presentation or written materials, and with an appointment for a follow-up visit. Going back to the basic frames message here based on this technique of motivational interviewing. So for example, the physician can say, "I'm concerned about your use of drugs," or "I'm concerned about what these drugs are doing to you," or "I'm concerned about the effects that these drugs are having on your social life," something like that. Here you're trying to express your concern as a clinician, as in a humanistic way to reach out to the patient. The patient has the ultimate responsibility for deciding what to do, and you can acknowledge that, and in some ways this empowers the patient. You would advise then a specific action. This is like Plan A. Ideally, what would you recommend this patient to do? You can also provide a menu of options, such these are the options for Plan B if your main plan is turned down by the patient. And you're trying to send the patient out of the office with at least an agreement to do something. 99% of the patients will agree to read about addiction and think about it and come back and talk about it. As I mentioned, we're really good about doing these things, but what we also have to do is acknowledge the suffering that this patient is in, and that it may not be easy to talk about, and that changing their behavior may be difficult. And you can empathize with this, and at the same time support their efforts by saying something like, "You can do this. You deserve better. You don't deserve to live like this." So here in review, let's look at this slide about the connection between prescriptions and the disease. This green line represents the number of prescriptions that have been written for opiates, and parallel with that line, in a direct correlation, are the number of deaths associated with opiates and the request for treatment for opiate dependence. And you can see there's this direct correlation. And the only way we're going to beat this back is by trying to limit the prescriptions that we write to only those that are appropriate. In summary, be careful with writing these prescriptions. These are potent medications that potentially have devastating consequences to the patient. Do no harm. Here are some important takeaways. Be careful with prescriptions for minors. Be on the lookout for professional patients who are looking to get drugs to divert to the illicit market. Use extreme caution when prescribing amphetamines to these patients. Avoid prescribing benzodiazepines and opioids together. Avoid prescribing benzodiazepines long-term. Consider random supervised urine collections for accurate sampling. And consider learning about how to prescribe buprenorphine and getting your, quote, X number from the DEA. Here are some other resources that are available for physicians who want to learn more about SBIRT, screening, brief intervention, and referral to treatment. There are a couple of sites, one here in New York State for OASIS and the federal site where you can learn more about SBIRT. OASIS has a reference page that you can access about treatment programs, and there's a Hope line that can also be accessed online. In summary, perform a careful clinical evaluation before prescribing opioids. Evaluate each patient for the risk of addiction, both past and current. Establish an accurate pain diagnosis with appropriate treatment goals. Prevent iatrogenic addiction by prescribing wisely. Continue to screen and monitor patients closely for the development of addiction with urine toxicology and by querying the state database. Intervene early when appropriate. Don't wait for the problem to get worse. And consider learning more about addiction and how to help these patients. This is Dr. Rick Blondell, finishing my portion of this segment on opioid prescriptions in New York State. Thank you very much.
Hello and welcome to the Opioid Prescriber Training Program Part 2, focusing on palliative care and end-of-life care. My name is Dr. Bob Waller and I will be your presenter today. I am a clinical assistant professor at the UB School of Pharmacy as well as the Director of Clinical Pharmacy Services at Niagara Hospice. This presentation was developed in coordination with Dr. Chris Kerr, who is the Chief Medical Officer at the Center for Hospice and Palliative Care here in Buffalo. Today's learning objectives will be to outline the principles of and the differences between palliative care and hospice care, and to describe the use of opioids in hospice and palliative care, specifically cancer pain, dyspnea, and methadone. To introduce the topic, 2.6 million individuals die per year in the United States, with approximately 1.6 million of them under hospice care. However, although those numbers seem relatively high, the median length of stay in hospice service is only 17.4 days, meaning many of our patients don't have enough time to benefit from all the services of hospice. Palliative care, then, is a specialty focused on quality of life. Any serious illness, whatever the diagnosis may be, whether it's cancer, heart failure, COPD, dementia, qualifies for receipt of palliative care. And the Center to Advance Palliative Care has estimated that approximately 6 million individuals could benefit from palliative care on an annual basis. Palliative care also involves teamwork, team practice, where physicians, nurses, social workers, spiritual care all participate in addition to physician assistants, nurse practitioners, pharmacists, nutritionists, physical therapists, occupational therapists, and other disciplines as needed. The World Health Organization has defined palliative care as the active total care of patients whose disease is not responsive to curative care. Yet we often look at palliative care to start before they have determined that curative care is no longer responsive, because we often don't know if curative care is going to work or not. It's patient and family-centered care that optimizes patients' quality of life by anticipating, preventing, and treating suffering. Cares through the continuum of the illness, addressing physical, intellectual, emotional, social, and spiritual needs. And it facilitates patient autonomy, access to information, and choice. So when should palliative care be considered for a patient? It should be provided in conjunction with curative care at the time of diagnosis of any serious or complex illness. It may be indicated alone when attempts at a cure are judged to be futile. Unfortunately, admissions to hospice and palliative care programs often come too late for optimum services to be provided. One of the things about palliative care is that it certainly improves quality, and we've referenced this slide quite a bit with numerous literature that proves this point. It demonstrates that palliative care relieves pain and distressing symptoms, supports ongoing reevaluations and goals of care and difficult decision-making, improves quality of life and satisfaction for patients and their families. It eases burden on providers and caregivers, helps patients complete life-prolonging treatments if necessary, improves transitional care management, moving between different levels of care, and reduces hospital length of stay. One study that outlines this concept is the early palliative care for patients with metastatic non-small cell lung cancer, published in the New England Journal in 2010. And I focused down onto the results. This was a relatively small study of about 151 patients, and they were randomized to either receiving standard of care or care with palliative care. And one of the findings was that despite the fact that fewer patients in the early palliative care group than in the standard care group received aggressive end-of-life care, the median survival was actually longer among patients receiving early palliative care. And in their conclusions, the authors state that as compared with patients receiving standard care, patients receiving early palliative care had less aggressive care at end of life, but longer survival. Palliative care is also cost-saving. It lowers healthcare costs by reducing hospital and ICU lengths of stay, as well as pharmacy costs. It improves the continuity of care between healthcare settings and increases hospice, home care, or nursing home referrals by supporting appropriate transition management. It helps the patients and families by clarifying the goals of care. It helps patients and families select medical treatments and care settings that meet their goals. It assists with decisions to leave the hospital or to withhold or withdraw death-prolonging treatments that don't help meet goals. So let's define hospice now. What is hospice? It's both a philosophy and a program that delivers palliative care. Again, it centers around an interdisciplinary team which provides expert medical care, pain and symptom management, and emotional, spiritual support expressly tailored to the patient's wishes. Hospice, by statute, is required to have 4 core disciplines: a doctor of medicine or osteopathy, a registered nurse, a social worker, and a pastoral or other type of counselor. Additional team members include pharmacy, bereavement, various therapies, including occupational, physical, music, therapy, and all sorts of volunteers. So how does a patient qualify to be in hospice? It is a Medicare benefit, and by definition, the terminal illness has to have a prognosis of 6 months or less as certified by 2 physicians, the patient's attending physician and the hospice medical director. Hospice care is provided under a number of different insurance programs, including Medicare Part A. Most public, private, and government health insurances will cover hospice care, as well as Medicaid in most states. And it's important to note that if a patient is indigent, we've had patients who are living under a viaduct somewhere, and they have no payer source to begin with. The foundations of most hospices are what takes care of the costs associated with those patients early in their care. And it's noted that in 2013, 92.7% of U.S. hospices did meet Medicare certification to provide the benefit to Medicare beneficiaries at no cost to the beneficiaries. Some hospice myths, things that are not true about what is required for a hospice patient. Hospice is only for patients with cancer. No, we in fact have many of our patients are heart failure, COPD, dementia patients. Again, any terminal illness qualifies for hospice. A DNR order is required. This is not necessarily true, although we encourage patients to have DNR paperwork filled out. Patients can't have an automatic implantable cardioverter defibrillator. Again, patients can have these, but as patients decline towards end of life, we often will have those de-accessed. Patient can't have antibiotics, IV fluids, TPN, or tube feedings. Again, we often limit those based upon a patient, but patients do receive all of those types of therapies. Patient can't have chemotherapy or radiation therapy. Again, untrue. We often use these types of therapies as palliative care to relieve symptoms that a patient might have. Patients can't have surgeries. Again, similar to chemo and radiation, patients can have this. A patient can't live alone. That is untrue. We do have some patients, they have to be a bit more higher functioning, but we do have some patients who do live alone, or that they can't have a full-time caregiver. Again, those same patients who live alone often don't have a full-time caregiver. It's not the best situation in the world, but it does occur. And the last item is that patients die more quickly than they would otherwise, which we will show you is not the case. So one of the things to think about is the concept in the past where treatment and curative care progressed throughout a patient's serious illness until such point that curative care was determined not to be of any value. And at that time, palliative care would kick in, and that would be the care that the patient would receive. Again, that's an older concept, and we've moved from that. The better concept is where both palliative care and potentially curative care would work in conjunction with each other and progress until the time of patient's death. And even newer concept to that is we understand that patients' conditions wax and wane, where at times they need more palliative care and at other times they need more curative care. And then finally, the most up-to-date concept of palliative care includes that at the time of diagnosis, palliative care starts automatically in conjunction with curative care. And you can see by this slide that patients and families both kind of progress through the same concept, where palliative care increases as the patient gets closer to death. Hospice care is invoked in that 6-month or less prognosis, but then notice that bereavement care continues for the families after the patient's death, and that's an important part of hospice care, is that the patients are cared for as well as the families after the time of the patient's death. So a little more to contrast palliative care versus hospice care. Again, palliative care is focused on quality of life for those with serious illness, and hospice is basically a subset of that, a subset of palliative care where it focuses truly on those last few weeks to months of life. One thing to note is that palliative care outside of hospice does not require a terminal diagnosis, nor do patients have to forego curative therapy at that point. Another way to contrast palliative care and hospice care is to look at the place, timing, payment, and treatment that it's associated with that. For the most part, palliative care has been in the hospital setting and more in the nursing home setting, but the new frontier in palliative care has been in home care and keeping patients at home. Contrasting that with hospice care, where primarily patients are in their own home. That is, surveys have found that most patients would prefer to be in their own home at time of death with their family around them. Hospice also occurs in nursing homes, and in more and more hospices, they have a general inpatient unit, a separate facility that focuses just on end-of-life care. And hospitals do take care of hospice patients, but that is becoming less and less frequent. From a timing standpoint, there's really no timing factor or no prognostic restriction with palliative care, while, as we said, there's a 6-month prognosis for hospice care. From a payment standpoint, there's emerging models of insurance coverage right now for palliative care, while the payment within hospice is inclusive of the interventions related to the diagnosis, including the medications. So the reimbursement is for just the palliative care of the patient. So for example, if a patient is in for cancer, yet they have, say, thyroid disease, the thyroid disease is not part of it. It's not going to be reimbursed under hospice, yet the patient's other insurance would still take care of that. By way of treatment, comfort care is used in combination with curative and/or life-sustaining therapy under the palliative care model, while under hospice, comfort care and quality of life are the only focus. Curative care is no longer considered at that point. Okay, now let's move into the use of opioids in hospice and palliative care, starting with cancer-related pain. One of the concepts that we use in hospice and palliative care is called portmanteau, where we look at the desirable properties of a medication. Oftentimes we are trying to minimize the number of medications and get the maximum effect out of the few medications that we use. So using this concept, a drug that would meet this criteria would have multiple therapeutic effects. So let's use morphine as an example, where obviously it has effects on pain, but as we'll discuss in a little bit, talk about the effects on dyspnea, as well as some of the side effects that we see with morphine, but are sometimes beneficial in our hospice patients, which may include sedation. So we also are looking for minimal drug interactions. Multiple routes of administration. Again, opioids do fit this property of portmanteau. Relatively wide therapeutic window, cost effectiveness, a convenient dosing schedule, and a known dose response and favorable ceiling effect. And to explain that, the ceiling effect with the medication is we can continue to go up and up with it without reaching a point where more doses will not have any more effect. So this is the World Health Organization's cancer pain ladder for adults, and I believe that's been presented in previous parts of this series. One thing that's important is that we've studied this ladder since its inception and found that there are some times when it doesn't necessarily meet the needs in a cancer patient. One study showed that it consistently failed to provide sufficient relief to 10 to 20% of advanced cancer patients in pain, particularly in cases of neuropathy pain and pain associated with bone involvement. Oftentimes, although it's stated that an adjuvant is added, those are often missed, and those adjuvants would be those medications directed towards neuropathic pain or pain associated with bone involvement. And presently in Europe, there's the TVT trial, where they're actually looking at this ladder and removing step 2 from it. And I point this out because many times patients come to us with cancer pain, and step 2 really doesn't help us at all, and we often progress to step 3 right away. The other critique of step 2 is what is an opioid for mild to moderate pain versus what is an opioid for moderate to severe pain. If we understand that morphine, oxycodone, and hydrocodone are relatively equipotent, which one of them would you consider first versus last? So we often move right through step 2 and into step 3. So where to start when you have a patient with cancer pain? It's based upon the initial treatment of the severity of the pain that the patient reports. And again, this goes back to some of the basic tenets of pain management, is how important assessment is to find out really what level of pain the patient's in and what type of pain that the patient's having. So again, for mild pain, we consider perhaps non-opioid analgesia. For moderate pain, we're definitely looking at opioids, and when we get to severe pain, we really should consider this a pain emergency. And if we remember back to some of the doses that you would give at this severe level, a IM or IV morphine dose of 10 milligrams or a PO dose between 15 and 30 milligrams would be appropriate to start at this severe pain level. So the next step is, after doing the assessment and determining where you want to start, is to get that prescription, get that medication to the patient. A PRN analgesic medication is the first step, with clear instructions is to take this medication if unexpected pain occurs, and to also include in that instruction that if that pain comes back, make sure you start that next dose. Do not wait until the pain becomes so severe that another dose won't be helpful. It's important that they know that they can take that medication whenever pain expresses itself. And the last part of this is call for an appointment to evaluate the pain problem. In our hospice situation, we reach out to them, and we don't allow this to go on too long because we want to evaluate how effective this regimen is, as well as make sure that we move to some of the next steps. And we should never forget when starting opioid therapy that a bowel regimen should be started as well. So I bring you to this slide I call the dosing frequency conundrum. And if we think back to most of the prescribing information that we've seen about immediate release opioids, they often say dose them at 4 to 6 hour intervals. And this slide demonstrates that that often is not optimal. So if we look at this slide, this is based upon the blood levels of a drug given at every 4 hours. And the black horizontal line represents the line where pain threshold would be. So any concentration above that line and the patient would be in pain relief. And as we can see, as this represents every 4 hour dosing, that the relief may only last about 3 hours. And then the patient's pain returns, and if they're instructed that they can only take it every 4 hours, they have to wait in pain until that 4 hour time frame comes around. And if you look at the graph here, you can see that by the time they take the next medication and it gets back up to a pain relieving blood level, there's a window of 2 to 3 hours where the patient is in pain. And this is important when it comes to that dosing, and we in hospice, we often will dose immediate release opioids on an every 3 hour schedule. So what is the next step? I alluded to the fact that we only give, a day or so when we start that PRN medication. So the next step is to administer a long-acting opioid on an around-the-clock basis, along with an immediate release opioid to be used on an as-needed basis for breakthrough pain once the patient's pain intensity and dose are stabilized. So in a nutshell, we'll take a look at that patient a day or two down the road, determine how much PRN use they've had, and then put a long-acting opioid on board in conjunction with an immediate release opioid for any breakthrough pain. And just a listing here of those opioids with long-acting formulations, and as you can see, many of them do. I do want to make a point on methadone. Methadone is the only long-acting liquid available. As many patients with terminal illness, they can no longer swallow at some point or have difficulty swallowing. This is a great advantage in that we can use a liquid that does, by its own pharmacokinetic properties, is a long-acting medication. So then the question comes up about what about breakthrough pain and breakthrough pain medications? The first question that is often asked is which opioid to give. Should we give the same as the long-acting opioid, or should we give a different one? And we've researched this quite a bit and found that there are really no evidence pointing that you must give the same long-acting opioid and short-acting opioid, or there's an advantage from giving a different short-acting opioid from a long-acting opioid. Often what's done is giving the same both long and short-acting opioid because it's easier then to calculate the total daily dose of what the patient's receiving and make dosage adjustments as necessary. The next question that comes up is how much to give. And I've highlighted here, starting at a 10 or 20% of the total daily dose is recommended by a number of different organizations and different guidelines. So for example, if the extended release morphine dose is 60 milligrams per day, then a 10 to 20% dose based upon available dosage forms is about 5 to 10 milligrams as needed for that breakthrough pain. Sometimes you might want to give more to the higher end of that range. There is some evidence to say you can give a higher breakthrough dose, but you want to at least start with a 10 to 20%. You don't want to give too little. One of my former residents used to say, if we give too much, it's just like spitting in the ocean. There is really no benefit from it. The next question that comes up with breakthrough medications is how often to give them. Many of the tertiary references say, there's a 4 or 6 hour dosing that is appropriate for opioids, when the reality is, based upon the pharmacokinetics, and every 3 hour dosing is much more appropriate. If you look at the kinetics of the drugs, they often are greatly removed from the system by that 4 or 6 hour interval. And if we think about it, if we give a patient an every 3 hour dose, if they're in pain at 3 hours, they take it. If they're not in pain at every 3 hours, Then they wait a little bit longer and they take it when they do have pain. So it's, I think, more appropriate to give that medication at the intervals where they will actually start becoming to get into pain. And then the last question that we ask about the use of breakthrough pain medications is when to change that long-acting dose. And I really say that it's patient dependent. If we find patients who are using multiple PRNs during the day, 3, 4, or more, then that's really indicative of a time to change the long-acting dose to something a bit higher so that they don't have to use the breakthrough meds as often. The grayer area is when a patient is taking 2 or 3 per day. It will then be based upon what are the patient goals. Are they okay with that 2 to 3 doses per day? Would they like improved pain control, and then therefore we would increase that long-acting drug? Or are they concerned about side effects and they're okay with using PRN more often? So when it comes to that dosing, I usually say the trigger should be around 2 to 3 times a day is where you're having that conversation with the patient to determine if you need to go to a longer acting. We talked earlier about metastatic bone pain and where the World Health Organization ladder may not be as effective. So it's important to remember that adding either NSAIDs or COX-2 inhibitors or steroids are an appropriate treatment for metastatic bone pain. And they can be opioid sparing. Because we get at the root of the pain by using these anti-inflammatories, we can often use less opioid. So with the NSAIDs and COX-2 inhibitors, they are often useful for that mild to moderate pain and are adjunctive, as I stated. Unfortunately, though, they do have a ceiling effect. At some point, no matter how high you go with the dose, you're not going to get any more effect out of it. And especially in the elderly patients, toxicities including GI, renal, and cardiac become an issue in the use of these medications. To talk about corticosteroids, they tend to be anti-inflammatory and are in many cases, the drug of choice is dexamethasone because of its high potency, with a range of anywhere between 2 and 16 milligrams a day to start. With use up to 30 milligrams a day, and there's even reports using up to 100 milligrams a day. Additionally, corticosteroids have the effect of being antiemetic, appetite stimulating, antidepressant effects more in the stimulatory nature. The patients feel very activated when taking these, and that's often a part of their condition is that they feel very sedated, very lethargic, and it gives them a stimulated feeling. And then one of the last things to consider about corticosteroids is that, yes, we know that there's some side effects associated with them, but most of them are long-term. And unfortunately for our patients in hospice, those long-term side effects will never manifest because often the patients are deceased before they come around. Again, to address some of the issues that we discussed about the World Health pain ladder is the use of adjunctive agents or co-analgesics, especially with neuropathic pain. So anytime a patient has brain or spinal cord involvement or symptoms that are consistent with neuropathic pain, an adjunctive agent should be added. And often this is a misnomer. Many patients have more neuropathic pain than they do have nociceptive pain. So this neuropathic agent may be the primary intervention. One thing to note is that failure of one agent, even within the same class of drugs, is not predictive of other drugs failing. So it's important that we look at those classes of drugs to add, which include anticonvulsants, tricyclic antidepressants, and selective norepinephrine reuptake inhibitors. I titled this slide, "I Can't Swallow Tablets Anymore," because it becomes an issue with many of our patients as they progress towards death. And the quote that I have here is to use optimally titrated doses of opioids and maximal safe and tolerable doses of co-analgesics through other routes of administration before considering spinal analgesics. So basically what we're trying to do is to keep patients on oral medications because their desire to stay at home using any other routes of administration both become technically difficult in the home as well as sometimes cost prohibitive. So we look at things that are highly concentrated. Morphine has the Roxanol brand name product, which is the 100 milligram per 5 ml, or also 20 milligram per ml, also called the Intensol. Methadone has a 10 milligram per ml concentration, hydromorphone a 1 milligram per 1 ml, and oxycodone a 20 milligram per ml concentration. So these are all effective. If you think about, you can get a very high potent opioids into a patient with a very small volume. And routes of administration, again, those non-parenteral routes including PO, sublingual, transbuccal. And just to mention these, many studies will show that the pharmacokinetics of opioids, many are not absorbed from the sublingual or buccal space, but yet because we administer them in such a small volume, they are still swallowed by the patient. Opioids can also go through an inhaled, intranasal, rectal, or topical routes. Opioids are also available through the parenteral route, IM, sub-Q and IV, and I note here continuous infusion, that even through a subcutaneous route we can do continuous infusion with highly concentrated opioids, and we use process similar to hypodermal crisis so that patients can be maintained under pain control using the same concepts of PCA or patient-controlled analgesia, and they're also available through intrathecal administration. We've talked before about some of their side effects, and I note them as nasty, and it's important to adjust opioid doses for each patient to achieve the pain relief with an acceptable level of side effects, and monitor them both for the appearance of them and prophylactically treat opioid-induced side effects. Constipation is one that we know occurs in most patients and should be prophylactically treated. Nausea and vomiting occurs in a high percentage of patients, and often we will put antiemetics on board as soon as we start opioids, and just monitoring for respiratory depression and CNS depression. One phrase that is often favored when I do this presentation for nursing staff is, never forget, the hand that writes the opioid script is the hand that writes the laxative script, lest it be the hand that performs the disimpaction. Some concerns that patients have about opioids and morphine specifically is the concept of addictions. They don't want to be considered an addict. The NCCE cancer guidelines speak about clarifying myths and misconceptions about pain and pain management, and reassure patients and family caregivers that cancer pain can be relieved and that addiction and tolerance are not problems associated with effective cancer pain management. And the caveat to this statement is that we are concerned about addiction and tolerance in this patient population, but under good cancer pain management, those risks are low. And it shows that the rates of abuse and misuse in cancer patients range from, in some studies, 0 to up to 7.7%. However, the risk of diversion and abuse to others surrounding the patient is very real, especially in this opioid crisis that we're in, where knowledge that overdoses involving obtaining opioids from friends and family are what's occurring. And some important definitions that we need to remember is that tolerance, again, is that physiological adaptation to the presence of a drug where higher doses are needed to maintain the same effects. Where physical dependence is when there's an occurrence of an abstinence syndrome upon dose reduction, discontinuation, or antagonist administration. And addiction is characterized by behaviors that include impaired control over drug use, compulsive use, continued use despite harm, and craving. And then a term that has some controversy with it is pseudo-addiction. And this is something that is seen in our patients when they come into hospice programs. It's distress and drug-seeking behaviors that look like physical dependence, but they occur in the context of unrelieved pain. These behaviors subside when analgesia is achieved. So oftentimes we see pseudo-addiction as in those cases where, that immediate release opioid is given every 6 hours and the patient is left to suffer for the time from when it wears off to when they can take their next medication. Some other fears about opioids hastening death are a concern. And I listed a number of quotes here from a number of literature sources. So opioids and sedatives used for symptom control in the last days are not associated with patient survival. Opioid usage, even at high doses, had no effect on survival among cancer patients in a hospice setting. And patients who receive opioid increases at the end of life did not show shorter survival than those who received in no doses. So it's important, again, when presented with a patient who has fears about opioids, is to kind of relieve some of their concerns by giving them this knowledge. Now, when it comes to practitioners, we also have unfounded concerns about the possible life-shortening effects of opioids resulted in less than optimal symptom management and end of life. This was a study that looked at ordering opioids for patients. And then we also have information that although published guidelines are available, the research literature suggests that healthcare providers continue to hold some negative misconceptions about cancer pain and its treatment. So let's move on to the use of opioids in hospice and palliative care. Opioid use and dyspnea. So dyspnea in general, that difficulty that patients have in breathing, we think about it with lung cancer and perhaps heart failure and COPD, but hospice patients exhibit it even when the primary diagnosis is dementia as they progress towards the end. Some general interventions include positioning, air movement with a fan or a window, bedside relaxation techniques, limiting or discontinuing parenteral fluids, which can cause fluid overload. And oxygen is often used, but it's not universally helpful. Some patients respond to it, others don't. From medications that can be used, again, antitussives for cough. Many times we'll use anticholinergics to decrease secretions, anxiolytics to help with the anxiety associated with it, and then specific disease interventions, including diuretics and fluid overload, bronchodilators when appropriate in asthma and COPD, corticosteroids for a number of effects, including mass effect, COPD, asthma, inflammation, or pulmonary fibrosis, and then antibiotics when there appears to be an infection. But oftentimes we get down to using opioids for dyspnea. Opioids help relieve the sensation of shortness of breath, and in the opioid-naive patient, all you need are actually very low doses to provide relief for most patients. So oral doses on the range of 2.5 to 5 milligrams, or parenteral doses of about 1 to 2 milligrams. We find that more frequent dosing is more effective than using higher doses if the dyspnea is not adequately treated. So we often start with an every 3-hour regimen and then have to move down to an every 2 or every 1-hour regimen. Patients generally require a lower dose than is necessary for pain treatment. So we don't necessarily need those higher doses, the 5 or 10 milligram oral morphine dose. We can use the small doses, and again, the tenet of starting low and going slow is important for dyspnea. Mechanistically, why do opioids work for dyspnea? It's relatively uncertain. There's a number of different theories, whether it's diminishing the chemoreceptor response to hypercapnia and hypoxia. It may cause vasodilation, which results in decreased dyspnea due to the resulting reduction in preload and pulmonary congestion. It may result in a decrease in anxiety and the subjective sensation of dyspnea through a central effect. It may treat underlying pain that is causing the increased respiratory drive. One thing to note is that there's really no difference between morphine and any of the short-acting opioids. All of them will have the same effect on dyspnea. When it comes to long-acting opioids for dyspnea, there's a couple different trials. One in a group of COPD patients where long-acting morphine was given and there were significant improvements in the subjective dyspnea scores of the patients. Another one in another group that included COPD, cancer, and interstitial lung disease patients where 62% of the patients derived benefit, and the resulting number needed to treat was only 2. So only 2 patients were needed to be treated for 1 patient to have relief. One of the concerns, though, with using opioids in dyspnea is the potential for respiratory depression. And again, this is a small study, only 27 patients, 25 of them cancer and 2 of them ALS. They were given opioids for dyspnea. 15 of those patients were opioid naive and 12 were opioid experienced. And there was no significant rise in carbon dioxide or fall in oxygen levels in these patients. And all of these patients had significant symptomatic relief of dyspnea and a reduction in their respiratory rate. And just to summarize, I list here the national organizations that have supported the use of low-dose opioids for the treatment of dyspnea, including the American Thoracic Society, the American College of Chest Physicians, the American College of Physicians, and the National Comprehensive Cancer Network. So the last topic on use of opioids in hospice and palliative care is the use of methadone. Some of the advantages of methadone is that its duration of action is quite long. With single dosing, it can be 6 to 8 hours, and with chronic dosing, it can be 8 to 48 hours. It should be administered more frequently during the first few days of therapy, about the first 48 hours, so that it approaches its steady state blood level. It has a very large volume of distribution, and it takes a while to get to that steady state level. Some other advantages include that it has pain relief in patients unresponsive to other opioid therapy with diminished incidence of effects. And some of the findings are that it has extra mechanisms of action, including non-competitive N-methyl D-aspartic acid or NMDA receptor antagonism, as well as norepinephrine or serotonin reuptake inhibition similar to the SNRIs. It also has multiple routes of administration, similar to those I outlined before about opioids. And I just want to note that it does have that concentrated liquid formulation, the 10 milligram per ml, as well as available as a powder for compounding so that we can make it into different products for patient needs, including very concentrated sublingual products or even microenemas where we can use rectal administration. However, methadone dosing is a challenge, and there's almost any literature that you see about methadone, there's a caveat that says it should be used by experienced clinicians. Some of the complications when dosing are involving its pharmacokinetics, where from an absorption standpoint, it's highly bioavailable with often a rapid onset of 15 to 45 minutes. And although this is a little bit longer than some of the short-acting opioids, methadone can be used as a short-acting opioid or as a breakthrough pain opioid. It has a very large volume of distribution, with only 1% of the drug being found in the blood. This is due to its extensive tissue accumulation due to its lipophilic properties. And it also binds to alpha-1 acid glycoprotein at about an 85 to 90% ratio. And this is important because alpha-1 acid glycoprotein tends to be at high levels in patients who have pain and have inflammatory processes going on. Methadone dosing has further challenges based upon its variability in half-life and its interpatient variability as well. The mean half-life is about 30 hours, but that has a range on it of plus or minus 16 hours. So therefore, its time to steady state is anywhere between 70 and 233 hours, also known as 3 to 10 days. So we have a long time before it gets to that steady state with routine dosing. Methadone is also a challenge because of its metabolism and elimination, where this is actually sometimes an advantage. It is metabolized to inactive metabolites, so therefore it reduces toxicity compared with many of the other opioids. It is a CYP3A4 substrate, therefore its metabolism is inducible by known enzyme-inducing drugs. One advantage as well is that a significant part of its elimination is through the fecal route, and the renal excretion is only a minor route. We also find that ratios of morphine to methadone vary based upon the patient, anywhere from a 3-to-1 ratio to a 20-to-1 ratio. And this is often because those patients who have neuropathic pain, once we get them on methadone, they can be treated well with a much lower dose of opioid overall. When dosing it, we need to take into account these pharmacokinetic variables, and in naive patients, typically starting with 2.5 or maybe 5 milligrams 2 to 3 times a day is an appropriate starting dosage. When converting from other opioids to methadone, we typically are looking at doses in a 5 to 10 milligram dose 2 to 3 times per day. And I want to note that there are multiple methods of converting other opioids to methadone, and to use this last statement here, that practitioners are advised to consult with a pain or palliative care specialist if they are unfamiliar with methadone prescribing. Because of all this variability, it's very important that you get some experience or you reach out and get some help in prescribing methadone to cancer patients. Some monitoring parameters that are important is that the patient must be closely monitored until methadone reaches that steady state concentration. Again, it could be anywhere between 3 and 10 days. So especially in our home care patients, we educate the family regarding on how to monitor the patient, including watching their respiratory rate and level of consciousness, their ability to be aroused, and their pupillary response. But once peak serum levels have been obtained, potential problems become much less likely. One thing to keep in mind is the potential for methadone to cause QTc prolongation, and in some cases it's appropriate to use ECG screening and monitoring while the patient is on methadone, and particularly be aware of the fact that concomitant QTc prolonging drugs may be prescribed, and there is an additive effect with all of those medications. So finally, to summarize, when we're looking at patients in palliative and hospice care, one of the goals that we want to achieve is what's called a good death. It's being treated as an individual with dignity and respect, being without pain or other symptoms, being in familiar surroundings, and being in the company of close family or friends. The National Hospice and Palliative Care Organization states this means being physically comfortable, at peace in your own home, surrounded by your loved ones, and doing the things that you love to do up to the very end. And in summary, some key concepts. Palliative care should be implemented at the time of diagnosis, simultaneously with curative or life-prolonging therapies. Opioid use at the end of life eases both pain and dyspnea. And methadone is an important tool to address both nociceptive and neuropathic pain, but must be used with caution. I'd like to thank you for your participation today, and I hope you enjoyed the presentation.